So again, pretty summarized to come like short, like more summarized than PANCE pearls, I guess, right? Because people know I hate PANCE pearls. So we'll see about that. So again, MSK in a nutshell, and to be fast, we're gonna start with ortho first. Fractures, what are the most important fractures? Not most important as far as they're gonna see in life, but as far as we're gonna see in the test, right? So what do we need to know for the test? Okay, first, Cooley's fracture. So we need to know the description, okay, as far as describing what happens to the volar side, the palmar side of the hand, and the dinner fork deformity. Don't just depend on memorizing the dinner fork or the name of the deformity, because they can describe it. Okay, so there's displacement to which side, volar or dorsal, which is going to be again the garden spade versus the dinner fork, and the Cooley's and Smith. So we need to review those as far, again, the name of the fracture, Cooley's Smith, the name of the deformity, and what happens in the deformity as far as description. Usually both these don't come as x-ray, most commonly as pictures or descriptions. If they come as an x-ray, they are harder. So I don't think I've seen them as x-rays in question banks, but as pictures. The next one would be the scaphoid fracture, which again, very important because we want to detect it, because again, it can be missed on the x-ray early on. And if we miss it, it's a problem because again, it has complication for avascular necrosis. So we had discussed this before. And remember, you do again, if you don't see it, okay, you do a splint and you re-image, re-x-ray after a while. So we're gonna splint anyway, whether we see the x-ray finding or no. Again, tenderness over the scaphoid bone with a history of trauma, that's enough. It's a scaphoid fracture. Okay, moving to femoral neck fracture, again, elderly, fallen lateral hip, short limb, externally rotated. I have been here on the wards for 4 days. We have already 2 cases of neck fracture, so very common. Again, open reduction to nerve fixation, and be careful about a complication from fat embolism, so stroke and PE. So be careful about that. Again, next is posterior knee dislocation. Needs heavy trauma like major injury, motor vehicle, whatever. Pain, laxity. Again, need to do neurovascular exam, pretty well neurovascular exam, because again, it's very common or high risk for popliteal artery compromise. So that's again, posterior knee dislocation. It's not gonna happen until again, it's a severe accident. So not like, I fell, I hit my knee, stuff like that, no. Again, another high hit on the test, compartment syndrome. Again, buildup of pressure inside a closed compartment, most common in the leg, can happen in other compartments, but again, the most common one in the leg. Pain out of proportion, so severe pain for the trigger that triggered the pain. Remember the 6 P's, the pain, the poikilothermia, the pallor, the pulseless, the paresthesia, and the paralysis. And remember, we're not going to wait until the pulseless and so forth, because it comes late. We have to suspect early. Again, fasciotomy is your key answer on the test. Yes, you can measure pressure if you want to, but for the test, your answer most probably will be fasciotomy. So keep that in mind. Rotator cuff injury, again, wear and tear or traumatic. Sits muscle, remember who are the sits muscles, supra, infra, teres, and subscapularis. So you need to kind of review those, what their action, because their action will be affected, right? What's the nerve supply? Again, supraspinatus is the most one to be injured. Okay, you're gonna have pain with the ARC test. Again, this is a muscle injury, so most diagnostic is MRI for muscles, anything that's muscles. We can do the dynamic ultrasound, but it's operator dependent. Again, PT, supportive therapy is your goal. Surgery if they are young, okay, and the course of the disease will affect their life, so for quality. But again, first is PT and supportive treatment. Carpal tunnel syndrome, again, overuse, look for occupation. All of us are typing now, so it's not an occupation anymore, right? It's a lifestyle. Numbness along median nerve distribution. Again, the thinner muscle wasting, the weekend grip. Tinel, FANL, remember tinel is, again, know the name of the test, description of the test. So tinel is tapping on, again, the volar side of the hand, right where the median nerve is, will cause like tingling, right? Fallon is when you ask them to, again, flex both wrists, right? Hard, like bring your hands together. Yeah, like how Ms. Gonzalez is doing it, right? I don't know why my camera's not on, but I look horrible. Okay, and again, PT, your splint, we can do steroid injection, we can do relief surgery, so multiple options, but always start with non-invasive, conservative, then gradually go up. So be careful when you are choosing the next step or what the question is asking for, definitive or initial and stuff like that. So all of these are options, but again, we always take it step by step to escalate, especially on exam questions. Okay, next to move with, again, back pain. Look for red flags in exam, which is your first bullet. Physical exam, PE is important. Look for red flags. Remember what are the red flags? Okay, so numbness, okay, paresthesia in saddle area, right? Urine or fecal incontinence, stuff like that. We already had, I think you have reviewed them in MSK, you have reviewed them in neuro, so look for the red flags. And again, imaging is not indicated if it's not going to change the management. So if the PE is negative, no red flags, I don't need to do imaging. I will just do conservative treatment. If the conservative treatment fails after, 6 weeks of NSAIDs, whatever, light modified exercise, all those conservative treatments, PT, then I can think about imaging. If the PE was positive, had something positive like neuro, positive exam, then yes, we can do, of course, MRI. But again, if imaging is not going to change your management, then don't do it. And I'm saying this, and when, I know you have seen other stuff in the hospital. Everybody gets an MRI, everybody gets a CT, everybody gets whatever. But again, imaging is not indicated unless it is exam is positive. Okay, we move to pediatric ortho, and if you remember, I had told you before, like I think 7 of my 40 questions on the exam were pediatric ortho. Though it is a small topic, but it's very high yield. So we need to review pediatric ortho. If you don't review ortho, just review pediatric ortho. For sure, you're going to have questions on pediatric ortho. So the first one is a Salter-Harris classification. And for your class, no, not your class, I think, yeah, for your class, I think in particular, no, the previous class, I don't remember. There was this confusion about the mnemonic because people were just seeing the word through and just going through the mnemonic. It's a 4, but remember, you have to know your bone part. Know what's the epiphysis, know what's the metaphysis, know what's the physis or the plate, and read the sentence where the fracture is going through what to what, okay? So don't just use the mnemonic. The mnemonic makes it easier, but you have to be careful reading the description of the x-ray finding. There could be an x-ray too. So the x-ray is easier actually than to apply the mnemonic than the description of the x-ray. So again, know your classification, which one is which, and the description of the fracture in each of those. So if it's above, what's the fractures going through what? So know your bony parts, okay? Legg-Calvé-Perthes disease, again, age is important. So young age, 4 to 10, okay, the gait is important. Remember, we need to put the femoral head within the acetabulum because it's important for the growth. Otherwise, that kid growth will be affected, the limb growth. So the length of the limb growth, right? So we need to contain the femoral head within the acetabulum with orthosis, again, we need to make sure to correct any residual femoral deformity surgically, okay? Usually these patients will have hip replacement early in life because, again, the joint is damaged, but we're trying to save whatever is there as much as we can at time of presentation. SCFE, more common, you're gonna see it in life. Okay, so SCFE is considered Salter-Harris 1, which is based on the classification, it's separated growth plate. Okay. Again, adolescent, obese, hip pain, more acute presentation, mostly in boys, referred to the knee. So any pain, any adolescent coming with knee pain, we have to think that it might be coming from the hip. Again, X-ray, frog lateral position is a key to kind of, you see the widened fisses, right? And the treatment, we have to fix it. We have to actually surgically fix it. So again, we do a reduction and fix it in position. Well, we if we do like open surgery, then we do pinning. Okay, so we need to bring it back again in place. That's very important. This is disability here. If you don't fix this, this kid is going to be disabled. Okay, so you need to keep that in mind. Osgood-Schlatter disease, different topic, not hip, it's knee. Okay, active adolescent, running, jumping. Again, they keep pulling on that tibial tuberosity to the point that, you know, a little bit of bone microfractures come out and they are in the tendon and they cause pain, inflammation, particularly pain on squatting. Again, tenderness over the tibial tuberosity is another key finding in the exam. No surgical intervention here, just NSAIDs, rest, hamstring exercises. It usually resolves. Sometimes, you know, it leaves like a little bit of calcification in the tendon later on, but it's not painful or deforming. Okay. Any questions on ortho? I know this is fast. I'm skipping. I'm just picking high yield topics, guys. So just keep that in mind. Any questions so far? Everybody sleeping? Okay.
No questions.
Okay. So rheumatology, again, gout, remember metatarsal, grade 2. You read crystals, remember it's needle-like negatively, so we need to know negatively or positive and the needle-like. Remember that, again, if they have, by chance, we find people with high uric acid, we don't treat them if they are not symptomatic. Again, in acute attack, we're aiming to treat inflammation, arthritis. We should address the uric acid later, but not during the acute attack, right? So remember, we can address it by NSAIDs. We can use steroids. We can use colchicine too for the acute attacks. Textbook wise, though, if they ask you, you will go for the indomethacin or the NSAIDs, but there are, like now, studies show that steroids are equally effective. Or, but again, for toxic boys, I guess we want to stick to the NSAIDs at least for now, for your test. Okay. Again, we can add colchicine again for the acute attack and for the chronic as well to prevent future attack. For chronic management, we're going to use allopurinol. Remember when to use allopurinol. So patient had more than 2 attacks per year. Patient had chronic kidney disease. They need to be on long-term management with allopurinol. If patient, this is their first presentation, but they have tophi or skin nodules, then you should start long-term management as well. So know the indications of starting long-term management with allopurinol. Okay, pseudo-gout, again, these are the CPPD crystals. They are positive for fringes, they are rhomboid in shape, and knee is the most commonly affected. Again, treatment-wise for the acute attack, it's the same as gout, but why do we need to differentiate? Again, textbook-wise in the exam, you're going to do aspiration for diagnosis, right? In real life, we don't do aspiration for diagnosis. But those people don't need allopurinol for long-term treatment. Okay, but again, just the initial, the acute attack, usually NSAID, similar fashion, because you're actually treating the inflammation of the acute attack, right? So it's a similar treatment. And remember, again, for the exam purposes, if they ask for diagnostic, then it's going to be the joint aspiration. Okay. Rheumatoid arthritis, again, inflammation, destruction, deformity. criteria is very important. So again, 6 weeks is very important. Symmetry is very important. Again, the RFC NTCCP or the elevated ESR and CRP, these are used. These are not a must. We don't have to have them, but they are used to do the score. You know, the scoring system. You need to have 6 points. Remember to diagnose rheumatoid. But if you have multiple small joints and symmetry and 6 weeks, these will make your 6 points. So you might not need RF and NTCCP for diagnosis at this point, or you don't need their points. But again, these are the criteria to calculate your score. So again, 6 weeks, symmetry, the number of joints, the smaller the joints, they get higher score. Again, you need either RF or NTCCP for a point, and the ES or CRP elevation for 1 point. Okay, and then we go from there. Remember, DIPs and low back are not affected. DIPs are low back are never affected. So this is kind of, you have a patient that has multiple joint pain, blah, 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 and they tell you that the DIPs are affected, then you need to scratch rheumatoid out of your differential for the vignette. Okay. So again, fatigue, anorexia, these are general for all rheumatology presentations. Nothing, you know, specific, right? Stiffness, symmetry, again, that's very important, right? And then we need to look for the deformities. The deformities are not going to happen overnight, remember, guys? So the deformities are not going to be present in early rheumatoid case. The deformities are going to be present for people who have been, you know, uncontrolled or ignoring the diagnosis for a while. So again, but look for the boutonniere. They are high on the test. Okay, you can see them in real life too. But these are we're not gonna depend on them for diagnosis because they happen late, right? But again, know how to description of boutonniere, know the description of the deformity, the ulnar deviation on the X-ray can be used, and it's easily to diagnose the ulnar deviation on X-ray. Again, you're going to have nodules, you're going to have eye manifestations. Again, for exam purposes, know the Felty and the Kaplan syndrome, because these are like the rheumatoid plus whatever. So again, patient coming with rheumatoid manifestations plus splenomegaly, and they give you a CBC and the white blood count is low, then the answer is going to be Felty syndrome. So again, look for these cues. Again, Kaplan syndrome, the history of working somewhere, risk factor for pneumoconiosis, blood plus lung presentation, plus joint pain and symmetry in the hand. So again, connect the clues for these syndromes. They are high yield on the exam, so don't miss them. They're easy questions. Just try to connect the clues. Okay. Treatment, again, we're aiming to reduce inflammation, preserve joints. So early detection is a key. Early detection is a key. That's why sometimes even if the R rheumatoid factor is negative, but you know, and that's why we have the scoring system, right? To start early. We're not going to wait for a rheumatoid factor plus. Sometimes it's negative all the time. DMARDs are your first choice and going to be your first choice on the exam all the time. Okay. Again, NSAIDs alone are not appropriate. They can be added to the DMARD, but DMARD is your key. Corticosteroid, again, on and off, they can be added with, you know, flare pain, blah, 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 whatever. They do help with slowing disease, but we cannot keep the patient for long-term treatment, so they are added on. We can add also TNF inhibitors, plus methotrexate. This is kind of a good combination at the moment. Again, adult onset Still's disease, late teenage. Okay, the key here, the fever, the rash, the fever, the rash. Fever comes, rash comes, fever goes, rash goes. Diagnostic, easy vignette, don't miss it, please. And it comes a lot in the exams. Okay, so fever comes, sun rash, fever goes, rash goes. Ignore anything else, and so forth, and that will be it. Again, treatment and NSAIDs, again, for your first line, and you take it from there afterwards. SLE, another big category on the exam. So criteria of diagnosis, remember, we need a positive ANA with a titer above 80. So that's a must, plus any other 3 of the following. Okay, so ANA above 80 plus any other of the 3, which is the rash, photosensitivity, or any of the kidney, neuro, or immunological manifestations. So again, remember the criteria of diagnosis. You need to count your criteria of diagnosis. Drug-induced lupus, again, is common in exams. Again, you're going to be a patient with a malar rash on their face, blah, 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 whatever. And then you're going to hint here and there, oh, that they have been diagnosed with, they've been in contact with TB, for example, and they start an isoniazide. There's your key, okay? Or they have been, I don't know. Again, the most common famous medications for the vignettes are listed, but there's more. There's a lot more. But again, just look for a history of a month or so starting new treatment, and then the patient started having the photosensitivity and blah, 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 blah. Think about drug-induced lupus. Remember, the antihistones are the antibodies to go for if the question is asking about, and if they're asking about management, your first thing is stop the drug. So keep that in mind. Crust or limited scleroderma. Okay, remember what they stand for: the calcinosis, Raynaud's, the dysmotility, the sclerotic telangiectasia. Again, you need 3 of the 5. You don't need the full 5 to diagnose crust. By the way, okay, you only need 3 of the 5. 3 out of the 5 to give it the crust diagnosis. So don't look for the full 5 in the vignette and come say, oh, but they did not have one of them. No, you need 3 out of the 5 to go for it. And remember, again, most commonly they will ask about the antibody, which is the anti-central. Shifting gears to polymyositis, dermatomyositis, again, 2-in-1 sisters, right? So it can be polymyositis alone, or we can add a skin manifestation to make it a dermatomyositis. Okay, remember, muscle weakness is a key. Muscle weakness is a key, particularly proximal muscle weakness. If it is dermato, then we're going to have like the rash on the dorsum of the hand, or we can have the gluten papules. Okay, so again, can happen alone or with skin manifestation. Polymyalgia rheumatica, though, pain, stiffness, no weakness. So again, polymyositis, weakness. Polymyalgia rheumatica, pain, stiffness, no weakness. Okay. So that's the key, the muscle weakness, to differentiate between, again, polymyositis and polymyalgia rheumatica. Polymyalgia rheumatica, anemia with ESR, again, we give prednisone as a treatment. Again, if there's no improvement, then we having a wrong diagnosis. So let's reevaluate. Giant cell arthritis, again, the sister of polymyalgia rheumatica. So they can come together or they can come separately. Okay, so again, there's two sets of twins. Polymyositis, dermatomyositis. The other set of twin is polymyalgia rheumatica, giant cell arthritis. So these are twins. Again, giant cell arthritis can happen on itself or coexist with polymyalgia rheumatica. Okay. What happens here? Headache, scalp tenderness, visual symptoms. Okay, patients say lost vision and come back, whatever. Jaw claudication is a very important key. Jaw claudication. So they have pain as the progressive pain with eating. Okay, remember, we're scared because of blindness. So we want to initiate high steroid right away. Okay, it's urgent. Okay, elevated ESR, 100% sensitive, but even if the ESR is not elevated and we clinically it is. Okay, so we're gonna start high dose steroid. Confirmation temporal artery biopsy. Do I wait? Do I have to wait for the temporal artery biopsy? No, I just have to start treatment right away. We can do also temporal ultrasound. Okay, but again, it's operator dependent. Okay, shifting gears to seronegatives, ankylosing spondylitis, men, young. Okay, progressive pain, stiffness of the spine, stiffness in the morning. Okay, elevated ESR, it's remember RA negative and TCCP negative. The HLA-B27 is not diagnostic, it is an association. So we don't even have to ask for it. So if they ask you what lab test you wanna run and they give you an option of HLA-B27, don't pick it, please, because it's not diagnostic. It's not gonna make a difference whether it's a positive or a negative. So why run it, okay? Again, radiology is a key. You can see the sacroiliac joint changes and the narrowing of the spaces in the bamboo spine. Bamboo spine is not going to be from day one. It's progressive. It's at the end. But you're going to see the changes progressively over the X-ray. Again, treatment NSAIDs, first line, physical therapy. We might need also like respiratory, like physiotherapy, because with the progression of the disease, the respiration becomes, lung issues arise, okay? Lung issues arise with respiration and so forth. And then again, TNF inhibitors if they're not responding to NSAIDs. Then psoriatic arthritis, again, psoriasis, then we get the arthritis. Psoriasis might be cleared at all before the arthritis arise. So in real life, history is important, because maybe by the time patient presents with arthritis, you don't see any skin manifestations. But again, history is important. This one is asymmetric or symmetric. Remember, everything we talked about, rheumatoid, blah, 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 is always symmetric, right? This one is asymmetric or symmetric. So what else is asymmetric? Osteoarthritis is asymmetric, right? Septic arthritis is asymmetric. Psoriatic is asymmetric, so keep these in mind. There could be sacroiliitis as well, like a pain and inflammation in the lower portion of the spine, right? Again, it's associated with HLA-B27 positive, but please never ask for it on an exam or in real life. Again, X-ray, the pencil and cup deformity is characteristic for exams, whether, again, they show you, so know the X-ray, how it look like, and remember the description. And I don't think they will ask you for treatment, particularly for that. It's mostly going to be for diagnosis, and I don't think the treatment is required from you guys. Okay, reactive arthritis. Remember, this is no C, no P, no climb the tree. Okay, the writers for reactive arthritis. So again, men, again, HLA, I don't care about it. Again, could be precipitated by GI infection. Okay, again, you have oligoarthritis, conjunctivitis, urethritis, right? I can see, can peak, can climb the tree, right? So keep this in mind, and the treatment is NSAIDs. And I think that's it, because again, it's short. Now, I took more than the time allotted to me, I believe, but it is short and quick. And it's the mostly high yield. I know we covered a lot more in class, but you need to focus on, again, the high yield ones before anything else.